So very quickly, I introduced myself early. I'm Joyce Chevalier. I'm the founder and president of the Cook's Nook here in Austin, really trying to bring nutritious solutions to healthcare and into food security in our public sector as well. And I am really, really excited that we get to bring you the next 3 panels, which are going to focus on the issues of food resilience, access, and equity in different arenas. Oh, look at these guys. The first group we're going to get a chance to talk to are some friends in the healthcare space, and then we're going to have some folks in the food school space. And then we're going to have another panel that's actually quite local about how you move the needle in Black health and what has it taken here in Austin Travis County to affect this change on the ground. So I'm going to move over to the side here. Hey, y'all.
Hey.
These are a pretty good-looking crowd for 8 a.m., I'm just going to tell you. So, I'll bring up my notes here because I don't want to mess up anything. And so this panel is the future of healthcare is food.
Or it might be the future of food is
healthcare.
Future of food is healthcare.
Is healthcare.
I think we debated on that.
I know.
Yeah.
And so we've got 3 friends here. Let me just introduce them very quickly. Firstly, right next to me is R.J. Briscione, who's the principal of the Focus Group Consulting, who I met used to be with one of the very large insurers here in the U.S. Next to him is Julianne Eckert, who's the Senior Director of Clinical Quality Programs with Clover Health, a wonderful, huge health organization. And at the end, our friend Paula Gutierrez, who I also met, used to be with one of the very large healthcare institutes. She is a health equity leader and SDOH disruptor. Also in this space, these guys are so connected across the United States about what's happening and how healthcare is starting to think about, there's only so many answers you can do when you create pills, medicines, and products. At some point, you have to ask about what and how things are being consumed and how does that actually work towards health. And so, I'm going to give you guys a few seconds. You want to tell everybody any details, a little bit about what you are and what you do and what you want to say about that, and then we'll jump into some of the questions here.
Yeah, sure. Looking forward to this. Thanks for having us. R.J. Briscione, I'm out of Atlanta. Spent about 15 years with health insurers. I'm in a small consultancy now. It's actually part of a slightly larger consultancy, but most recently at Aetna and then CVS, which some of you may or may not recognize. Aetna is now owned by CVS Health, which is, kind of goes into how we talk about feeding into the system. I led social determinants of health there, so thinking about all of the things that we can do that don't happen in a doctor's office. Our former CEO used to say 80% of what happens to your health can't happen in a doctor's office or a hospital. I'm starting to realize I think it's even higher than that. And just like you're not supposed to have a favorite child, there's a lot of determinants. There's housing, there's transportation, there's everything. Food was definitely my favorite, so glad to be here.
Yeah.
Thanks, Joy. My name is Julianne Eckert. I'm a registered nurse, and I'm the Senior Director of Clinical Quality Programs at Clover Health. And I've been a nurse for almost 30 years, more than I care to count. However, working in the inner cities as well as on the health plan payer side since 2001 with case management and helping members prevent from falling through the cracks. Most recently, I've been with startups and a health tech, Clover Health, where our mission is to improve every life. And the majority of our population live in the top 5 ADI deciles. And so we actually go to market in underserved areas, and we wrap benefits, provider support, and other tools so that they can optimize their life and, not have to make a choice between food or medicine or rent.
Good morning, everyone. Joy, thank you so much for having us. This is amazing, tremendous. Thank you all for joining us this morning, bright and early. I am Paula Gutierrez. I'm the Senior Director of Social Care and Partnerships at Cityblock Health. It is a value-based care provider based out of Brooklyn, New York, that focuses on low-income and Medicaid patients, also focusing very heavily on their social determinants. I joined Cityblock by way of CVS Health, which is how I met my friend RJ and Joy, leading their health equity work for their kidney care division, focusing on patients with chronic kidney disease and end-stage renal failure. Prior to that, I led health equity, diversity, and inclusion at a healthcare system in New Jersey, which is where I hail from, and started my career in the nonprofit space, also focused on organ and tissue donation and transplantation. So much like a lot of us that are here today, food to me is also incredibly meaningful, poignant. It's literally been the livelihood of my family. My mother has cooked for our local community for over 30 years. So being able to lean into this work is very humbling, I will say. So I don't take this lightly. It's, to whom much is given, much shall be, demanded of, and that's what we're here to do. So thank you all. Excited
we're
to
really
chat with you
fortunate to have really great friends and partners like these guys who are committed to ensuring equity and access in healthcare, and particularly the food and nutrition components of healthcare. So you guys all mentioned the word. For those who don't know, there is a concept called the social determinants of health. And I wanted to give, how about you want to start, RJ, and sort of just give people a general definition so, we can, because we're going to use that word a few times.
Yeah, sure, thanks. So the social determinants of health, sometimes referred to as the social drivers of health, are the conditions in which you live, work, play. People like to add a lot of fun stuff in there. There was one yesterday, I think, that was pray, thrive.
Pray
right?
and slay,
So,
I think it was.
And slay, yes. So it's everything around you, the entire environment. The built environment, actually, is something that we did a lot of look at. So really, again, it's 80%, we believe. It's a kind of round number of what actually drives health outcomes is all of those conditions. So if you think about, Maslow, if you think about those kind of things, right? Are people going to go fill their prescriptions if there's, a few bucks left in the bank account and they don't have food on the table, right? And so what are the things that we can do holistically, ideally matching that with their actual either disease state or needs? How can we get, one of the big things we can get into probably in a little bit is the data. How do we understand what those members' social needs are? We speaking as we in the health insurance world have a pretty good idea. Lots of people like to think we sit on all the data in the world. When I went to go do this and try to implement this, meaning bring in social determinants and really try to affect them, we don't have data on what members' social needs are, right? We don't know what their exact housing needs are, so we have to figure out...
Transportation needs, right? Think about the relationship between food access and just the pure act of having transportation. That's one of the key drivers.
Food's a little bit easier because if we know the member has diabetes, has end-stage renal, has certain conditions, we can try to match food to that in a little bit easier way it's a little bit easier to get the data on that. So that's, I'll let others chime in here on their thoughts.
Yeah, I think it's really interesting because, if you think about it, every member is like a snowflake. Each one is completely different. And we can, at Clover, we have an intake assessment called health risk assessment. So we take a number of social determinant of health questions when the member first enters a plan so we can start to develop a persona. However, like I always used to train my case managers, you never know what's going on the other side of that phone. And like I said, every member is a snowflake. And so you don't know if in their house that our population is primarily seniors, that they're diverting their food to their grandchildren or, what other barriers that they could be facing in their communities, whether it's an underserved area or even if it's in the middle of a suburb where you wouldn't even think that there would be food insecurity. And so we try to screen, like as you said, RJ, and then we work to make real-time referrals to our care management teams. So.
Yeah. You want to add anything
about
definitions that you guys use?
Absolutely. Yeah, I would say for us at My Kidney Care, we really leaned hard into food, particularly because of the clinical implications for patients with chronic kidney disease and end-stage renal. Mm-hmm. So ensuring that, we talk about fresh and healthy food and access to food, and oftentimes what we might think is healthy very much is, but for patients with certain chronic conditions, like those with kidney, can have a high potassium intake, protein. You have to be very mindful of those things. So, kind of double-clicking into the food aspect and ensuring that the food that they are getting is not just fresh and nutritious, but also modified for their diet and their clinical conditions, because ultimately it affects their clinical outcomes.
Or the food not undermining, the health goals that you guys are working with them on. Go ahead, RJ.
Yeah, one thing that I learned early on that some people probably heard me tell this little story before, but it bears repeating to different audiences so people don't make the same mistake that I did. One thing we saw, Paul and I actually went to a panel yesterday at clinical trials, so trying to get more patients into clinical trials. There's a lot of parallels here, right? And one of the core principles of that is design with them and not for them. And we were working with people early on with literally the best intentions in the world, and I think we did a little bit of designing for them. So just briefly, we did the first food intervention we did that was at some scale was for basically a whole community in Miami built around the school, built around the elementary school. And we did every other week we had massive deliveries of fresh food, and then we built in a shelf-stable pantry into the school so that they could come pick up the shelf-stable items anytime the school was open. But on those fresh food delivery days, it's essentially kind of downtown Miami. We learned later, or we figured out later, most households may have one car. That one car was being used by the dad or the grandfather that was out at the job, right? And so it was the moms and grandmoms walking out of the school, and it's Miami. We're getting amazing fresh melons and lots of, the takeaway is going to be like 30, 40 pounds of food. I'm watching them spill it walking down the street struggling, and I said, all right, we got to do something completely different. So I can get into later what we did to address that. But so the point there is you can't address a single social determinant in isolation, right? So you have to design for truly the whole person.
Yeah, absolutely. So what has driven, I guess I maybe have alluded to it, but what has really driven the shift for payer providers to rethink including food? Most people don't realize that your payer providers, your insurers, your ACOs, your alternate care organizations, and others are some of the biggest movers and prime movers of food products around the United States, right? We tend to think about food in terms of restaurants, or we think about it in terms of retail, but there are a whole other places that move a heck of a lot more food than just your grocers, not to diminish grocers. But what has driven that shift, do you guys think, for the papers, in your terms, and what you guys saw from inside? You want to go, Paul?
Yeah. I would say for us at CVS, one of the biggest drivers of looking at investing in food is really the cost, right? If we look at, for example, our members, we had some subsets that had higher readmission rates, to the ED for different reasons, but a lot of them were nutrition related. So if we can feed folks properly, that there's also an ROI to that, right? From a payer perspective, which unfortunately is a part that we have to look at and be very realistic about. But it also drives engagement for our members. So looking at what needs are we meeting for them, and also having them not worry about something, because oftentimes, and RJ made a point about this, if you have to worry about where you're going to get your next meal from, how you're going to get your child to daycare, you're not going to be adherent to your treatment. So when it comes to something like food, which is so integral and core, investing in medically tailored meals, right, which is what we were working on with the Cook's Nook, takes one less step out of their day. And for individuals who might be a single parent, right, with two children, two school-age children, having that meal at your doorstep that is tailored to their diet, to their chronic condition, means the world to them, and it makes things much easier. So really, to answer your question, it's one, it certainly drives engagement for our members and increases satisfaction, but also you see better clinical outcomes. Unfortunately, there's not as much literature as we would like on the clinical benefits of that, and I know that there's a lot of folks out there doing pilots to work towards that, which is something that we struggled with, right? From a clinical perspective, do we know that there's evidence, is this rooted in evidence-based?
Yeah.
And there are some folks out there that have done the work, but my hope and what I'm seeing is that more both private and public partnerships are doing the work to be able to have some more data that supports it. But I would say is those two pieces.
Yeah. Julianne?
So at Clover Health, I'm over the clinical quality programs, and one of the way that we measure health is through some key quality metrics to kind of get a pulse, like how well is a diabetic's hemoglobin A1C controlled, how well is their blood pressure controlled, and those start to give us some signals. And what we've done is when we get a sense of those cohorts that aren't doing so well, then we start to wrap around the programs for them. But actually how we build our entire design of our plan actually tackles SDOH. I think as payers, we have to get to the point where we're designing our plan, our benefits, and our affordability around social determinants of health, especially with the proposed rule that's coming in from CMS and the reward factor going away and plans being judged, getting a bonus of the health equity index. So we're going to be held accountable for that. So, but when we build our plan benefits, one of the things is, we have in and out of network parity. We know that members are much more likely to go to a primary care physician in communities that they trust, that they live in, that are culturally appropriate, who they identify with. So most of our plans have a $0 copay, whether they're in or out of network, because we feel that a member is more likely to go to a PCP if they're able to, choose that person who they identify with. Additionally, for affordability, we also have Live Healthy rewards that we just instituted. And what that is it drives health literacy. It also drives engagement with health and with their providers. And the cool thing about it is that we give them a preloaded Live Healthy Reward Flex Visa card. And as they do these literacy videos, these predetermined set of tasks, they get money loaded onto their card up to $400. And as I was saying earlier, each member is a snowflake. Your need for food might be completely different from yours, or you might need transportation. So, they can't go out and buy firearms and alcohol and all that fun stuff, but they can use it on anything. They can use it on food. They can use it on boxes of produce. They can use it on so many things so that they are able to tailor it to what they personally need for their own barriers to overcome for those.
One can't overestimate the need for the ability to create solutions that are culturally appropriate and relevant to the household. That is the way you're going to get engagement, long-term compliance, and eventually the improved outcomes from folks. And any ways that folks can do that and organizations can do that, you're seeing more and more of that. And I'll just also mention the lack of data here, and we're going to let RJ talk about that here in a minute too. This lack of data becomes essential. We may know instinctively that, of course, what you eat is going to support, the condition that you have or the structure you have, or just having access, right, and trying to keep a household from being food insecure. That's huge, but there's still a need to show it and to prove it before you start to see this all-in conversation that so many of us would like to have. Sorry, go ahead, RJ.
No, awesome. Almost like we planned that tee up.
Oh.
So some data. There's a really great organization out of UCSF called SIREN, which is Social Intervention Research Evaluation Network, I think. SIREN. They just put out actually a meta-analysis on all of. So they study. They exist to study social interventions for health, right? And so they just put out a study, a meta-analysis of medically tailored meals. So we're getting a little healthcare wonky with definitions, but medically tailored meals, meaning if the member has a specific condition, you send them meals, you give them meals that are specifically tailored for that condition.
Meals that are fit for renal patients, meals that are fit for diabetes patients, or hypertension, heart healthy, focused meals, things of that nature.
So in that meta-analysis, they have a 37 to 52% reduction in healthcare costs across the board, which is those are insane numbers for healthcare. A 70% reduction in ED visits. And so that translates to about $2,500 per member per year.
ED visits, emergency.
Sorry, I'm in healthcare world. Yes.
Yeah.
Emergency visits. Thank you for pulling me back out. I was trying really hard.
Going down the hole.
And then, so those are huge numbers in our world, right? And then the $2,500 a year, that's a huge difference. Yeah. Most people probably don't realize this. Health insurance runs on very tiny, sometimes upside down margins. So that could be all of the difference to a health plan, and that is net cost of the meals, $2,500. So the evidence is there. We may get into this in a little bit. It's really, really hard to bridge evidence across for some reason that those of us that work on this internally at places, I think, like, just have trouble. You have to see it in your own population to believe it, and this world is run by somewhat older medical doctors that say, like, guarantee me what the ROI is going to be on this set, and I'll let you do it, right? We've had this discussion, right? So that's, we're getting there. Those evidence bases are building up. As I was finishing at CVS, I had a really great one running with a very tight experiment with folks on getting meals with the express purpose of social intervention, lowering their food insecurity, right? Mm-hmm. So we measured their food insecurity quarterly, and also their A1C. And when that spreadsheet came back from the provider's office, so the doctor's office where they were getting it, my boss, who was a doctor of 30 years, didn't believe it. Said there's no way that these A1Cs are going down this much just on this food intervention. And I said, I'm not the one putting it in. I'm not doctoring these.
Yeah.
So yeah. So it's happening, but it has to happen in each little fiefdom, unfortunately, for right now.
What that sort of says, though, right? When I don't know if I myself am a former diabetic, but what happens typically is you're diagnosed with something and you're given a pamphlet and say diet and exercise and good luck. But the idea that there's senior executive management who doesn't quite believe that even is supposed to work is kind of interesting, right? But you're handed the pamphlet, right? So I'm sorry. Do you guys want to add anything to?
Yeah, I think I concur with what RJ said, because we actually partner with Walgreens, and we've embedded health corners into our communities that are the top 50% of the ADI deciles. And what that means is an area deprivation index. It's a scale of 1 to 10, 5 and over. Getting closer to 10 means the more burden and disparities that your community may face. So what we did is we put health corners in where our most populous concentrations of members who lived in those type of areas. And what we found was those members organically in New Jersey, because 90% of our population is in New Jersey, they organically started to come to these health corners, these Walgreens pharmacies that were in their neighborhood, and started to engage with these pharmacists. And they started, lo and behold, they started taking their blood pressure multiple times a month. The pharmacists began educating them on DASH diets. And lo and behold, now that instead of like, hey, we've got a blood pressure and it's uncontrolled, we can see that we're trending down because they have that continuous support, and it's not just sending a mailer of like, hey, you should be doing these things to take care of yourself every year. And so we're starting to see that trend shift, and that's starting to set up for, and I know we're going to talk about a little bit later about pilots of trying to get efficacy and, basis for actually building these to scale our entire populations.
Wow. Paula? You're good? Okay. All right. So just real quick, we can talk about pilots, but, let's go back to right before the pilot. As decision-making leaders, what do you guys look for in order to decide that some funding is going to happen, or program is going to happen, or you've got the population to design a program? What is the decision-making that you guys sort of think about to get there? And I'll let you start, Paula, at the end.
Yeah, thanks, Joy. For me, one of my mantras and tenets has always been to make sure that the dollars that we're investing are invested in the best way possible. And, to piggyback on what RJ had said at the beginning of our conversation around social determinants, if someone has a job, if you provide employment, or if you have access to employment, you don't have to, there's a lot that you can do with that, right? You can get to and from places. You can get access to healthy foods. You can have an education. So I share that because, for us, when we were looking for a partner for medically tailored meals, and we had the chance to meet Dwight, Joy, and Amy here at the Cook's Nook, it was really a no-brainer because we were looking at investing in the community here in Austin. And what better way to start with investing in a local business? So if we are employing our communities and investing in those thoughtfully, then it really is that downstream impact that you're providing you're filling the need for all these other determinants. So all that being said, not just because we're here, but I've said this to you guys before, but the model that you have to provide food is incredibly special. And what we were looking for is, because in the kidney population, a great number of our patients are people of color, right? They're Hispanic, they're Latino. So ensuring that those meals that they were getting were designed with a cultural lens in mind was paramount. You know, food is so central to all of us, right? It's community, it's gathering. And to be able to make that as special as possible with a meal is incredibly valuable, and that was not lost on us. So, you know, oftentimes you see all these other companies that do provide meals, but you know, they're very bland, and it's not aligned with the cultural needs.
Non-identifiable.
Yeah, right. Or it's like, what is this? What are we looking at?
High sodium.
And then you layer on that the nutrition value. So, you know, we looked for partnering with a local business that was helping the same community that we're looking to influence, right? The fact that it was a minority, woman-owned led business was incredibly special. So looking at investing locally, investing in individuals who may not have had the opportunity to own businesses historically, right? We all know history around that. So that was really the differentiator. So I'd say, you know, for companies like CVS and others that have billions of dollars, it is a lot easier sometimes to work with the bigger names out there. And it may not be as easy to work with smaller partners, but it does drive a much bigger impact, right? Because you are that downstream impact of focusing on companies like Joy's help the same community that we're looking at influence. And, you know, we talked about this before, is that trust factor. You know,
a trust
the
chain
community.
there, right?
There is that trust factor. You're here in the community. Listen, I'm from Jersey, and before I worked at CVS, I'd never been to Texas. So I was not going to come in here and pretend like I knew this community. So working with you, working with our patients, and listening to them and saying, what are your needs? How can we help you do this? And let's do this together. Let's partner, right? Let's design with, not for, like my colleagues have said here. So I'd say a lot of those different aspects are what we looked for when we were looking at a partner to invest with.
Okay, thank you, ma'am.
Well, I think with us, I mean, we start more organically, and we look at what is the problem we're trying to solve. And our former CEO, Vivek, I spent a lot of time with him in my earlier days of Clover, and, you know, he gave us room to fail spectacularly. And knowing that when we build it once, you know, that it, you know, there's a lot of change management. It may not go like we thought it would. But that gives us freedom to start to develop and innovate, which is how we've developed many of our tech solutions like Clover Assistant, et cetera, but working backwards from what we're trying to solve. And, you know, to your point, there are a lot of big players, and Clover is not one of the biggest plans, so we can be small beans. So finding partners who are willing to collaborate with us and our unique needs and our unique membership and the ability to pivot quickly. Also working within, we are silo busters throughout our organization. So we embed quality and health equity in our DNA. And so we're getting ready to work on a new, project of bringing like pre-made meals and farm boxes into members' homes of our 20% of our most complex morbidity and mortality who have in-home care Clover physicians visiting them because they're too, they're not able to go to their PCP. So we actually hire our own PCPs to go into their homes to see them on a monthly basis and care for them. And, developing a project like that is now we know that we've got, the things that we need to do for prevention and wellness and chronic disease management, but finding the ways such as leveling up that next detail of how are we going to start to impact the control of their A1C through food as medicine, because that's the next big leap that we're taking, and also that's where CMS is going, is instead of like an NCQA.
All right, Sid, tell them what the acronyms mean.
National Coalition for Quality Alliance, and CMS is Centers for Medicare and Medicaid. Yes. They are, like I said earlier, they are holding plans accountable for health equity and addressing SDOH. And it's not just good enough to have an A1C value that's under a certain number. Now we're going to start to see that trend go to how well are they controlled over the year? How well is the blood pressure pressure controlled over the year. And food is such an integral part of that. We know that it's very emotional, it's community, and that is the next place where we're going towards now.
Yeah, it is social, it is ritual, it is everything. It's foodways, and unless you can put that in, give that as an option for people, and they're at choice and have dignity about that choice, and it looks and reflects them. I love how you guys say that, with, not for. I mean, that is going to get the compliance in motion that these programs are going to need. You want to add anything to?
Just a little bit. My colleagues here, especially pretty much everything Paula said, right?
What Paula said. That's pretty much our answer. But I said what Paula said.
I'll take it. I'll add one minor thought on top, right? We do always look locally. We do always try to do this locally. However, the other question that I always got from the people that would approve this and give me money to do it, in addition to, like, what's the ROI right off the bat, is how can you scale it? Right? So we want to work locally with you. We want to be here in the communities. Most of my healthcare career is in Medicaid, where we really have to do that locally. Our customers are the state.
Yep.
And the state wants to see us having partnerships on the ground, right? So then how do we get you, for example, partners that can help you scale that up locally, right? Like, how do you join a platform? How do you join something that can get that food out to all of Texas eventually? Yep. Or, if you were working with a Medicaid plan here, or then how can you start to go regionally? That's really hard, right?
Yeah.
Like, I can give you today how to do it, in Miami for a small area for a couple thousand people. Getting it up to the millions of people that we have on the Medicaid rolls is a little difficult.
Yeah. And just Texas by itself fulfills any of these requirements.
It is a whole other country.
Yeah, it's a whole place. All right, I want to make sure that we have time to let folks ask questions, trying to figure out what I haven't asked for. You want to talk about real quick, how about we just go to the questions? We got 8 minutes. You want to go to the questions? I want to talk about pilots. You want to talk about pilots?
We did pilots.
We did pilots?
Well, yeah, I think the question is why pilots, and it's mainly what I just said, right? Like, how do you, because every buyer's different, and every buyer's got their own thing, and every buyer's got their own, you have to be approved, and you have to, there's a lot of hoops you have to jump through.
There's a lot of hoops. And
so if you can get in a pilot and prove it, and then you can get some of those numbers that we talked about earlier on the results, and then start to scale up, then you're on your way. Because if you do well in pilots, I guarantee you it's just as painful for us, for the people that are sort of your sponsor, bringing you into the organization for all the hoops jumping, than it is for you. We don't want to bring another and another and another and another, right? Like, if you do well, we're going to partner with you and keep it rolling.
Keep going. Go ahead, Paul.
Yeah, to the point about pilots and scalability, some of the work that we were doing was also outside of Austin, right? So, it was a little bit more challenging to work with Joy and her team, but I think that's an interesting point in who we're looking to partner with, because I always bring it back to the community and the trust aspect. As much as scalability is incredibly important, and we do need to think about that, having sort of that blueprint of what we need to do, but then tailoring it to the community that you're working with, right? We were working with you guys here in Austin. We had a community also in outside of Chicago that we were looking at doing some very similar work, and the blueprint for this work is very similar, but the needs of that community were far different. So, when we think about scalability, we have to also think about meeting people where they are and tailoring it to their particular needs, because it's I always say this, it's not a one size fits all. What works for me may not work for Joy or RJ or Julianne.
And these little tiny consistent innovations in thinking and thought and process and community and populations inside these big companies, these are huge. It's folks like these who are trying to talk to those within their organization to get that organization to think about doing this work differently. So we got to support these guys as much as we ask them to support us. We have to support them internally as well. So go ahead, Julianne.
I was going to say, I think one thing, too, is that, as a health plan, it's like we can't ourselves operate in a vacuum. One of our core tenets is making sure that, we're improving every life. Well, part of that is the critical relationship between a patient and their doctor. And if we're operating in a vacuum and doing all these great things with the best of intention and all these great plan designs and benefits and all these things that, are great tools, keeping that transparency with that patient's provider and physician so that they're involved in that care throughout the entire journey, that is so critical for us. And that's one of the things that we've worked to do, is to increase that transparency and support those physicians, especially in underserved areas. If you think about in and out of network parity, and in the U.S. we're already in a doctor shortage anyway, but if we have narrow networks and patients are choosing between going to a provider they trust or going to someone into a network, that's across town that is more difficult, they're less likely to go. But what we do with our providers in these underserved areas is we have the Clover Assistant, and that is a tech-enabled, driven platform where we drive insights and information about that patient to the physician at the point of care while they're with those members at the bedside. And so they can see why, your patient's telling you that he's taking your statin, but he's really only taking it 60% of the year. Something's wrong. You need to talk to him.
Right.
Or we're actually doing this kind of engagement, et cetera, so that there is that communal there is a web wrapped around. It's not just the payer and the vacuum. It's not just the provider. It's all of us holding our hands around the member to guide them and prevent them from falling through the cracks.
Right, absolutely. These guys are fabulous. All right, we only have a few minutes left. Are you guys got any questions? Yeah, go ahead. Joe. Hi.
Oh, thanks. Hi, this was fantastic, guys. I had a question on ROI, and obviously the ROI story is easier to tell the higher the acuity of the patient. So if you have a patient with an A1C of 8, it's not a hard sell necessarily to put dollars behind their food, but how are you thinking about lower in the pyramid, where the larger groups of people with the lower acuity, and what makes a compelling ROI story for a plan for that population?
Are you a ringer?
Yeah. Where'd you come from?
I'm new. I work for Season Health. I lead products. I'm new in this industry. I came from the food world, so just the fact that I knew all of these acronyms, I'm feeling really good about myself.
Yeah, but there's a healthcare plant in the food world. Yeah, ROI. I'll jump. Sorry. So what I was trying to preach internally there, and I've talked with Josh and I've talked with Morgan about this, is there's a bigger ROI story to make with that social data that I talked about at the beginning, right? Like, ROI to me doesn't have to be only dollar over dollar, but you still have to get back to dollars inside the health plan at some point, right? And so there's a way to figure that out with the social needs of the member. If you find the data on the social needs of the member, know that member's food insecure, we can assign, this gets into big time healthcare economist world, which is what I was trying to do. You can assign a value to that food insecurity per person, right? Or any of the other determinants or anything like that, right? In addition to it's easier for diabetes, for renal, for those kinds of things, because the hard dollars. Also, these bigger meta studies that are just coming out now on this dollar value, that's an across the board dollar value, right? That's across Medicaid, Medicare, kind of everything, right? So there's starting to get to be a little bit more on that. Again, everybody's going to want to do it with their distinct population that they have. The world's not there on food for every patient yet, but I think bringing in that social data of the members' actual needs. We don't know how many members are food insecure, to be totally honest. We can take a pretty good guess at it based on, we know their income, obviously, if they're Medicaid, we know Medicare, but we don't know a lot else about them from the social world. So that's where I was trying to head.
Yeah. And I know for us, I always joke that if I blink, I need to show an ROI to my leadership team. So we've gotten pretty good at trying to work backwards. But
hey, at least they don't ask you when you just show up in the room. You got an ROI? So I just walked in the room.
I got that. I got a number. But actually what we do is we can take that and of what it impacts and how it impacts the population of scale and roll that up into some predicted benefit that we get that actually for us it's star ratings, which is a set of like about 40 quality metrics that if Medicare Advantage plans do well in, they actually get a reward factor and extra money from CMS that we pour then back into that relationship. So that's how my team usually proves that ROI, because it all rolls up into that, and so it's on predicted income.
Okay. Do you want to go? I want to make sure I get another couple of questions.
I was just going to add, another piece
Yeah,
of this too, that just to wrap up and to make sure folks also understand this a bit better, is looking at preventative measures and also looking at those members that aren't as costly, right? Because those are the easier ones because they're more complex. So it's easier to prove that ROI. But some of the work that we were doing is through Aetna and predictive modeling is catching some of those members that were at high risk for CKD before they became such a burden and so
chronic
costly.
kidney disease.
And there's going to be medical jeopardy jargon after this. Just FYI, make sure everybody's paying attention. So we have to also look at prevention and before folks get complex.
Too complex.
I think so too, and that's one of the things about the Clover assistant is keeping them healthy so they don't go down
they don't
that
get
path
there.
of getting there.
Yeah. I'm sorry, this lady had her hand up back there.
How did you solve for the rolling melons? How did you solve for the rolling melons?
The rolling melons, the
in
lady
Florida.
Oh gosh. So integrated transportation is the short answer there. So we did it at a clinic. Well, for that, I actually ended up carrying them down the street sometimes. But but we redesigned for a clinic that had transportation as part of the clinic's benefit, right? So the members would come there, they'd shop on this truck that we actually bought for Feeding South Florida. The members, they would come through, shop with an assistant based on their dietary needs, take it out, and then the van is literally waiting like down the breeze, like from here to the door for them to take them home.
I mean, that and integrating transportation it's almost becoming inherent in some pilots. You have to, in some fashion, right? Any other questions? Hi. Sarah's going to run all the way over there and give you this.
Okay. Hi, everyone. Great talk today. I did want to know more about the new CMS proposed rule, and you can talk about like the implications of your work.
Okay.
Good,
We didn't know we
Julianne.
had policy walks in the audience.
Healthcare policy walks in the audience. I love it.
Yeah.
At 8 o'clock on a Saturday.
Well, and just at a high level, the proposed rule, which came out by CMS in December, is what I would pretty much call mind-blowing, because it's really taken away the traditional way that plans drove performance in star ratings, including even risk adjustment of diagnosis capture. And what it's doing is, usually if I did well on a certain number of measures, I could guarantee that if I had they rate plans on a star level of 1 to 5 stars. So I know at 3.5 stars, if I'm doing well on my quality metrics, I'm going to start getting money back, additional monies back. Well, there are larger payers who do really well, even smaller payers, and they have more narrow networks, et cetera. But what CMS and NCQA, who leads HEDIS, which is a set of other defined quality metrics like prevention, screening, et cetera, is they're taking away that traditional reward factor and they're replacing it with a health equity index reward factor starting in, I believe we start getting measured 2025. And what that means is we're going to be scored on how well we are able to show how we address social determinants of health in our populations. And there's an early smoke signal for a lot of plans because NCQA and the National Office of Minority Health did a HES summary score pilot. And what that was is a health equity summary score, which is a combination of prevention measures and caps of member experience measures, and then weighted that on different factors such as LIS, low income subsidy, and race and ethnicity. And with Rise National, which is like our big think tank earlier this week, there's a lot of plans who've done traditionally very well in stars, but they didn't do well in HES because JAMA came out with an article a couple years ago that shows that plans who have disproportionately high numbers of people who don't have SDOH do better in STARS, where plans like us, who
Right.
have 67% of our populations in the top 5 ADI deciles, do worse. So we did very well in the HES summary. We were in the top 30. So we're pleased with the proposed rule because we feel like it supports health equity and the work that we're doing and just where healthcare really needs to go if we're really improving all
So
of our
more
lives.
HES, less stars.
What?
More HES, less stars.
Yeah,
Yeah.
yeah, exactly.
Yeah.
And better health will get you more stars in the future.
Yeah, and better HES will
That
get
is
you
the
more
future,
star
yeah.
ratings, right? Exactly. Well, we are over time. I do want to thank these ladies. These guys clearly are amazing, and thank you guys for being here. Thank you guys for joining us, and clap for these guys.
Thank you. for
And
having
we
us.
are going to relocate, and then you guys ready? These guys, we got another group coming up, and they're going to talk about a similar conversation, but it's going to be related to policy and around school food in that universe and those populations. So let us transition. I'll be right back.